All right, everybody had a little break, feel better? Pretty good? All right, so I'm going to be talking about chronic obstructive pulmonary disorder, which Dr. Wilhite and I were just discussing. It used to be chronic obstructive pulmonary disease, so that's probably what I'm going to end up saying about half the time, but either way. I'm going to start out with some pictures, because I like pictures. I was looking at some old school cool cats and kittens. So we got John Travolta here, Danny in Grease. Got his cigarette hanging out of his mouth there. Got a little John F. Kennedy. He's got his Cuban cigar there that he's pulling on right before the missile crisis there. Got a little Tyler Durden action. Anybody like Fight Club? He's got his cigarette going on here. And then Mia from Pulp Fiction. I hope this movie's not too old. She's pretty cool, right? So we're looking at all of these older images of cool people. Well, they've all probably got COPD now, because 80 to 90% of COPD deaths are directly related to smoking. I wanted to bring that up at the beginning because it's a big deal. And we're going to talk a little towards the end of the lecture a little bit more about that, but I kind of want this to be in the back of your mind while you're listening, because we all know now that smoking's bad, right? Like everybody knows smoking's bad. That's pretty much established. Most people know that. But people still smoke. So we have to think about why people are still choosing to smoke when we all know that it's bad, and the messages that people have received in the past about smoking and what we're seeing now more. So we'll come back to that. Right now we're going to talk about the objectives of this lecture, and I'm giving you these not just because they have to be here at the beginning, but also because this is what you should be able to do by the time you take this test. So we should be able to define COPD and the clinical presentation. You need to be able to explain the basic patho of COPD. You need to be able to tell me what causes the problems. The typical assessment findings on a patient, we need to know those. The criteria that they use to diagnose COPD. We need to discuss common medications. Guys, medications are huge, and there's only going to be more of it as you get closer to NCLEX. So you've got to know your meds. Non-pharmacological treatments, we're going to talk about those too. Oxygen delivery methods, I have some examples up here that we're going to look at. And of course, we're going to need to be able to provide basic patient education to our patients with COPD. So first, let's review what we know about the respiratory system. We just had our asthma lecture, so none of this should be new information, but I'm going to go over it because repetition is good. You've got your trachea, and that branches into your bronchi and your bronchioles. They're going to be important in COPD. And then at the end of the bronchioles, as they branch down, you get to your alveoli. These are the tiny little air sacs that's where your gas exchange takes place. Now, there are millions of these in your lungs. They're very, very tiny, but they have a large surface area. It's like something like bigger than a basketball court if you were to take all the surface area of your alveoli. There's a lot of surface area there that gas exchange takes place. In COPD, a lot of it has to do with losing that surface area. And we're going to meet Doris. This is going to be our patient for today. Doris is a 65-year-old white female. She's a current smoker, and she's smoked about a pack a day for the last 40 years. She has been noticing that she gets more short of breath with exertion. She likes to work in her garden, and she's getting short of breath when she's out gardening. Also, when she keeps her grandkids, when she chases them around, she's getting short of breath. She's had a cough for years. She blames it, of course, on seasonal changes. Every time the pollen comes out, my breathing and my coughing gets worse. And in the past few months, though, her cough has changed a little bit. She finds herself coughing up sputum a lot. So she's come into the clinic because she just assumes she's got some kind of little cold or infection. She wants you to fix it for her. Obviously, Doris has COPD, right? That's why we're talking about her. So, COPD, the patho of COPD is that airflow is limited, and it's progressive, and it's not fully reversible. That's something that we want to remember. COPD cannot be cured. There are two aspects of COPD, emphysema and chronic bronchitis. They used to be considered two different diseases, but they're so closely related that we now call it all COPD. Emphysema specifically has to do with the destruction of those alveoli, those tiny little sacs of air. And then chronic bronchitis, it's diagnosed with the presence of cough and sputum production for at least 3 months in each of 2 consecutive years. It has to do with narrowing of those airways. This slide, you don't have to write anything down off the slide. It's just a little information about the epidemiology. COPD is the 4th leading cause of chronic morbidity and mortality in the USA. This is a slightly older slide information, but it's projected to be the 3rd leading cause of death. The reason I'm telling you this is because if you are in any type of facility or nursing where you see people over the age of about 40 or 50, you will see COPD patients. It doesn't matter what specialty you're in. There are a lot of COPD patients, and you need to know about the treatment of them in their normal state and also during their exacerbations. There are other causes of COPD. 80 to 90%, remember, is directly related to smoking, but there is that other 10 to 20%. Occupational dust and chemicals. You will see this a lot in patients who have worked in like factories or coal mines, things like that, where they're around, like not just normal dust. Like normal dust is not what we're talking about here. We're talking about like I said, like mining dust or irritants, chemicals that they've been around and inhaling a lot. Outdoor air pollution, we really don't have as much of a problem with this in the US anymore because there's so many regulations about cars and factories and stuff, but they see this a lot in other countries where they don't have those regulations. Heavy pollution can cause COPD. Secondhand smoke is another one. You cannot have smoked a cigarette ever in your life, but if you live 40 years around a spouse or something that they are smoking every day, you can have secondhand smoke COPD. Then the last one I'm going to mention is a relatively rare cause. It's called alpha-1 antitrypsin deficiency. This is a genetic condition that can cause COPD. It can also cause liver problems. The reason I mention it is because this is what you would want to consider if you have a patient that's coming in that's maybe a little younger or they have no history of smoking or any kind of air pollutant exposure that they can tell you about. This is something you might want to consider. It's a genetic issue. It can't be cured, but if you know that it's there, then you have a lot more that you can do to work with them, treat their symptoms, and prevent the progression. Less than 5% of cases are alpha-1 antitrypsin deficiency. So we're going to talk about the remember you've got emphysema and chronic bronchitis. So patients can have both, and in fact, usually they do. Usually they're not just one or the other, but we want to talk about both. Emphysema is probably a little more complex. So what happens is you have injury to alveoli over time because of these inhaled pollutants, like the cigarette smoke. They get injured, and over time, they get stiff. They lose elasticity. So you want to think about these little tiny stretchy balloons. They start to get brittle. They get hyperinflated because they don't stretch back. And over time, those tiny little balloons can stretch and pop. And you have alveoli that basically collapse. What this causes is air gets trapped in those tiny little air spaces. So when you inhale in and breathe out, instead of effectively exhaling the CO2, it just kind of sits there and swirls. And so that, of course, leads to ineffective gas exchange. If you have CO2 just sitting there, what's going to happen to your CO2 levels? They're going to go up because you can't breathe out more CO2 if it's getting trapped there. So what happens is non-oxygenated blood, CO2, enters the bloodstream and your CO2 levels get higher. Now, we're going to talk about chronic bronchitis. This is a little bit simpler, but also important. Also, both of these, you notice, are caused by the inhaled pollutants. In this case, it causes inflammation to the bronchi and the bronchioles. So as this happens over the years, this is a chronic condition, the bronchiole walls start to get thicker. So they narrow because they're thicker. Then in addition to this, you start having production of mucus. So between the narrowing bronchioles and the mucus production, you have a much narrower airway that causes obstruction. And now, I have a video because to me the video helped to visualize this. It's on the PowerPoint that's uploaded to Blackboard, so if there's anyone watching at home, they won't be able to see this right now. It wouldn't fit on Collaborate. But I liked this because it kind of helped me visualize what's happening.
In normal functioning lungs, when air is inhaled, it travels down the windpipe and into the airways, or bronchial tubes of the lungs. Inside the lungs, the airways branch out into smaller and smaller tubes called bronchioles that are rich in blood supply. At the end of these tubes are billions of tiny air sacs, called alveoli. Normally, the walls of the airways and air sacs are elastic and flexible in nature. Inhaling causes each air sac to fill with air. Exhaling causes each air sac to deflate. Efficient uptake of air into the lungs provides oxygen to the blood, which is then carried to all parts of the body. In COPD, however, the airways become thick and inflamed, and they produce more mucus than usual. This mucus can clog the airways and makes it hard to breathe. In COPD, the walls of the air sacs in the lungs are damaged and lose their elastic quality. The air sacs get floppy, broken, and lose their shape. As the air spaces get larger, air gets trapped, and there are fewer air sacs to supply oxygen to the blood. Because air is trapped in these air sacs, it is difficult for lungs with COPD to deflate like normal lungs. This trapped air makes it harder to get fresh air into the lungs and makes breathing more difficult.
There we go. Does that kind of help give you an idea of what's happening? Get out of here. So this is just a picture of basically what we just looked at. Remember that the damage to the alveoli basically makes them collapse, and that's how CO2 just gets trapped. Instead of going in and out efficiently, it just kind of sits there and swirls around. So the clinical manifestations, this is what you're going to see with your patients. They're going to have increased work of breathing and shortness of breath, increased accessory muscle use. They're going to have to take more work to expand their lungs. And then tripod position. Do you guys know what tripod position is? Yeah. You've probably done it before when you were like running a mile for your PE class in middle school. When you're exhausted, what do? Right? So what that is just bracing, because instead of using the muscles of your torso to support yourself, you're working to breathe. So those muscles are being used to expand your lungs, so you brace yourself so that they can kind of work on breathing instead of holding you up. You will see this with your patients when they're doing their PT and walking in the hallways. And if it's particularly bad, sometimes they'll do it while they're sitting down. They'll be sitting, leaning forward with their hands on their knees. They also will have an increased diameter of their chest. We frequently call this barrel chest. You can really see this in your little old men, little old ladies. They'll have this big round barrel chest, and that's a result of years and years of those alveoli that don't, are constantly overexpanded. It makes their chest actually over time will actually be bigger. And of course, they're almost always going to have a cough. Increased sputum production. Remember Doris? Now she's having sputum. She hasn't had that before. Pursed lip breathing. We'll talk about that. We've already talked about it with asthma. Skin color changes. Sometimes they will be red and flushed where they're working hard to breathe. Sometimes they can be blue and cyanotic or gray sometimes. They will be anxious when they're having exacerbations. They will feel like they can't get enough air, and then your lung sounds crackles and wheezes. So blue bloaters and pink puffers. This is just a really good mnemonic device to kind of remember the differences in emphysema and chronic bronchitis. Now, one caveat to this, a lot of patients have both. So you don't always see the perfect pink puffer patient or the perfect chronic bronchitis patient. This is just sort of to help you remember which symptoms are more associated with which disorder. In fact, usually they have both, so they're going to have aspects of each one. With your chronic bronchitis, these are going to be your patients with the really thick, productive cough. A lot of times they're overweight, big, they have a big neck. They'll have more peripheral edema, rhonchi, wheezing, their lungs are going to sound wet or sputumy. You like that word, sputumy? But you can hear it rattle when you listen to them. And then elevated hemoglobin is one that I want to mention. What happens is your hemoglobin is actually high because they've been this way for so long that their body has started making more hemoglobin to try to compensate for the lack of oxygen. With emphysema, you're going to see these little old people that are really thin, really skinny. They'll have the big barrel chest. You'll be able to see it. They have really severe dyspnea with exertion. They just get totally winded from the slightest thing. Their chest, you may not hear as much noisy, wet sounds because they have those hyperinflated alveoli. So you will hear breath sounds that aren't, you won't be able to hear the congestion. And then their x-ray will show those big hyperinflated lungs. So let's talk about the effect on blood gases. This is important. This is something that you will definitely get questions on. So when you have trapping of air and that CO2, we already talked about it, someone answered the question, your CO2 goes up. CO2 is the acid in your blood, so what type of imbalance are you going to get? Respiratory acidosis, correct. With these patients, a lot of them are going to be compensated respiratory acidosis because they've been this way for a long time. So their CO2 is always high. Sometimes you'll get gases on these patients. Their pH will be normal, and their CO2 will be like 60, and they'll be just sitting there talking to you, chilling. So, like, they are used to it. This is how they live. So what happens is, as that happens over time, the kidneys compensate. Their kidneys just make more bicarb. You'll see completely or partially compensated respiratory acidosis with these patients. Now, when they have exacerbations, that all kind of goes out the window. The exacerbation means that their compensatory mechanisms are failing. So when they come in with exacerbations, then you may see the uncompensated respiratory acidosis with these. So to diagnose them, number one is history. We've been talking to Doris. She tells us she's been smoking for the last 40 years. If they're not smokers, what do you think you would ask them about? Secondhand smoke's a good one. We're going to ask them where they worked or what they did for a living, and go back a ways. Maybe they're an office job now, but when they were younger, they worked in a coal mine or something. You may want to go back. Spirometry, we talked about that with asthma. It's also important with COPD. And then the chest x-ray, you can't diagnose COPD with just a chest x-ray, but it may give you some information. If you can see the big hyperinflated lungs, that's going to be added to the puzzle. For the spirometry, forced vital capacity, maximum volume of air exhaled during a forced expiration. So they're going to exhale as hard as they can. And then FEV is forced expiration in 1 second. Now, why do we care about how much they can exhale out? What does that have to do with their disease? Right. So COPD, remember, it's an oxygen issue, of course, but COPD is also very much a CO2 issue. And a lot of times patients don't even realize that. They have to be able to get rid of their CO2, and they're having trouble with this with COPD. So we want to know how much they are exhaling with a single breath. And then the doctor will use those values to make the diagnosis. Goals of treatment. We're going to assess and monitor the disease. We're always assessing. Reduce their risk factors as much as we can. Manage stable COPD. This is going to be important for you with your patients that are not in the hospital for COPD. They're in the hospital for something else. This is going to happen a lot no matter what floor you work on. You may work in a cardiac floor and someone's had an MI, but they may also have COPD. So you're treating them acutely for their other problem, but you're still going to have to manage their COPD while they're in the hospital. And again, this is a huge population. You will see these patients. So managing stable COPD is actually very important for the nurse. We think about them being in the hospital for this, but you're going to be taking care of their stable COPD a lot. And then managing exacerbations, that's of course what we think about when we think about treating COPD in the hospital, where they've had something that's upset that balance and now they're exacerbated and in trouble. Medications for COPD. So you've got to know your meds on this and everything. We're going to go over these meds. I've got some pretty good slides made for you here, and you have access to those. Pay attention to your meds. They will be on the test. The first one's bronchodilators. I'm going to get into a little more detail about bronchodilators here. Beta agonists, beta 2 agonists. So we talked about albuterol. Albuterol is a beta agonist. Now, you've probably already had experience with the beta receptor with another class of drugs. Anyone recognize beta blockers? Yeah? So what effect does beta blockers have on my heart rate? Someone? I can't hear you. What's it do to your heart rate? A beta blocker. It decreases, right? Carvedilol, metoprolol, yes. Somebody back there going. So if a beta blocker decreases, I know you guys haven't had a lot of pharm, but a beta agonist is going to stimulate. Okay? So the side effects of a beta agonist, it's going to open our airways, which is what we want it to do, but it's also going to have a side effect. It will increase your heart rate. If you can learn a little bit about your med classes, it will help you so much, because then you won't necessarily have to memorize every single name. If you know what class something is, and you can't remember this med when you see it on a test, if you know what class it is in, you can use your deduction to figure it out. So this is a good test question. Fast heart rate. If you have a patient who is already in a fast heart rate, maybe they're in the hospital for AFib and they have a fast heart rate, and you have an order for a bronchodilator that's a beta agonist, you're going to at least question that order. You're going to think about what you're giving, right? You may give both. There's a lot of patients that are on both, but you're at least going to consider that. Does someone in here have asthma and use an albuterol inhaler? Anybody? How does it make you feel if you use it?
Very jittery.
That's right, jittery. It makes you feel like you got tremors, anxious, especially someone who doesn't take it very often and they take a big albuterol neb, they're going to feel super anxious. So that's something you would think about. Now, anxiety is not a contraindication. A lot of times the patients that can't breathe are super anxious. You're still going to give your beta agonist. But you also want to think about it if you're using it long term. You know, these are the side effects it's going to cause. We talked about albuterol. You should know that one. You should know it with your eyes closed. There are other beta agonists. Salmeterol and formoterol are two that I listed. They're long-acting. They are not good for rescue inhalers. It will not help because they don't act fast enough. Notice the suffix on there, that terol, albuterol, salmeterol. The long-acting ones are better for management, but they still have the same effects on like heart rate and stuff. The next bronchodilator that we're talking about is anticholinergics. So they do the same thing. They open up the bronchi. They have less cardiac effects than the beta agonists. So that's something to keep in mind. If you have a patient who has cardiac problems, you might want to consider anticholinergics instead. They don't have the same side effects. Usually what you're going to see with these are dry mouth and a bad taste in their mouth. This ipratropium, the Atrovent, you will see this in your clinical. Like any patient on breathing treatments is on Atrovent. And then the last one we're going to look at is inhaled glucocorticoids. They're steroids. What do steroids do? Anybody know? Come on. Well, they don't bronchodilate. That's a good guess, though. It's on there. Someone say it. Yeah. So steroids, and steroids are not going away ever. So get steroids in your head. Steroids reduce inflammation. They suppress the immune response. So side effects of these steroids when they're inhaled is oral thrush. That's a yeast infection in your mouth. Now, why would you have a problem with yeast infections in the mouth with a steroid? Let's think about it. Because if we know why, it helps us to remember it. Right. So your mouth is full of bacteria, right? And normally our immune system, it's totally fine. Bacteria lives there, your immune system keeps it in check, everything's good. When you have an inhaled steroid, that steroid gets in your mouth because that's the way to your lungs. So if you're constantly inhaling steroids every day, that can cause a reduced immune response in your mouth, and you can get a overgrowth of yeast, which is thrush. So the way that we fix that is just to tell them to rinse their mouth out. It doesn't necessarily have to be with like antibacterial or anything, because we're not getting rid of the bacteria, we're getting rid of the medicine. We want the steroid out of their mouth. So after they use their dose inhaler, they need to rinse their mouth out if it's a steroid. Fluticasone or Flonase, some of you guys may take that for allergies. That's an inhaled steroid. And then budesonide, that's Symbicort you're going to see. A lot of these drugs, when you see them in clinical, they make them in combos. They'll put two together so that they only have one neb to take. So you'll see those a lot. Metered dose inhaler use. We talked about this earlier, so I'm not going to go over it too much. It was already on your little quiz. On my PowerPoint that's on Blackboard, you have videos, and I recommend, if you're a visual learner, watch those videos through at least once. That way you can kind of piece it together in your mind when you have questions on the test of ordering things. They inhale as they're pressing the MDI, and they're going to hold their breath for 10 seconds. And then we're also going to mention, your book calls it an aero chamber. I've always heard it called a spacer, whichever you call it. This is for people who may have problems coordinating their motion with the hand and breathing at the same time. So mostly you're talking about kids and older people who have lost some of their dexterity. They're going to have trouble pressing and inhaling at the same time. So you use this little spacer, and it basically just traps the medicine in a small space so they can press it and then breathe normally, or breathe deeply normally for 2 or 3 breaths, and it will help them get their medicine. That's something that as a nurse you can consider, like if you're asking your patient, hey, why haven't you been taking your inhaler? A lot of times with older people, you will notice that they have trouble using it, and that's something very easy that you can do as a nursing action to help them make sure they're getting the most out of their meds. Exacerbations. This is when they're going to come in the hospital for COPD. The meds are very much the same. You have the bronchodilators. You may see oral glucocorticoids, so oral steroids to get more of a systematic response. Antibiotics, because they're at high risk for pneumonia, superinfections. Of course, we're going to give them oxygen. And then we're going to talk about non-invasive positive pressure ventilation. Oxygen therapy. One thing to note with COPD patients, too much oxygen on these patients can be dangerous. So I'm going to give you kind of the Cliff Notes version. A normal person, so all of us, I assume, have a hypercapnic respiratory drive. What that means is your brain is constantly monitoring your CO2 level every breath you take, and when that CO2 moves up just a little too much, you take a breath. So like 15 times a minute, your brain, your hypothalamus is measuring this and causing you to breathe. It gauges the CO2, and that's how it tells you to breathe. So with these patients who have chronic high CO2, what's going to happen? Their brain is going to have to change its thermostat a little bit. Their CO2 is always high. So what it does is it swaps over to what's called a hypoxic drive. And I know this is kind of deep stuff, but it will help you understand why you can't do this. With COPD, the CO2 is always high. So your brain swaps over to measuring oxygen, and when the oxygen drops a little too low, it tells them to breathe. So these patients are going to have a lower SAT normally, all the time. A lot of times they'll walk in, they'll be talking to you normal, not short of breath, with a SAT of 88. This is normal for them. So if you give them too much oxygen, if they walk in for an exacerbation, you go, oh my gosh, their SAT's 88, and you throw a non-rebreather on them. You come in 20 minutes later and maybe their respiratory rate is like 8 instead of 15, because it's going to suppress that drive to breathe. So what you do is you ask for orders. You might tell your physician, hey, I'm checking his SAT. I think his SAT's a little lower. He's a COPD patient, and get different parameters for these patients. And also, you're probably not going to reach for the non-rebreather first if their SAT is low. Oxygen delivery systems, we talked about these a little bit, and I really wanted to pass these around, but with COVID we can't. So nasal cannula, that's the one, everyone knows a nasal cannula. 1 to 6 liters, we talked about the percentages earlier. Humidify it if you can. Most of the time we want to. Then we go to a simple face mask. This is also just measured in liters. This can be if they need a little more than 6, or also if they're mouth breathers. Some patients just breathe through their mouth more, and the nasal cannula doesn't work as well. Same here, you still have to humidify it, and you can only go up to about 8 liters on this. Venturi mask, you're gonna see this more in the hospital, you may see it in the ER. It allows you to titrate your percentage of oxygen and, hang on. There are different kinds, but usually they'll come with this little baggie of the little attachment here. And I wish I could hand it around, but they're color coded, and then also written on the little piece will tell you what percentage it is. So basically you can just change them out depending on what percentage you want. A lot of them also, instead of having like the different ones, will just have a little click wheel, like it'll have a little dial on it that you can adjust. But it will say on the attachment what percentage you're putting them on. And then it'll also tell you it'll have a number that tells you how many liters to adjust your flow meter. And then last of these is your non-rebreather mask. It has the reservoir on it. If it's got the little flap on here, then it's a true non-rebreather mask. If it doesn't, it's a partial rebreather mask. It goes up to 100%. Again, don't reach for this first with a COPD patient because you can give them too much oxygen with these. And then next, we're going to talk about, this one. So I added this slide even though it's not really in your book, because with COVID, these are becoming ubiquitous, and you will most likely see them when you're on your clinicals, and I want you to know what it is. There's a new little device we have called a high-flow nasal cannula. And what it does, it can go up to 60 liters per minute. It's got a special little nasal cannula that goes in their nose, and it's super humidified. It's 100% humidified oxygen, so it doesn't dry their nose out. And each machine's a little different, but you can titrate between 35 about and 100% FiO2. It's a newer therapy, but we're seeing them so much, I felt like I need to put this in this so that you'll at least know what it is when you see it in clinical. And then BiPAP, this is an important one. Non-invasive ventilation. It's basically a ventilator without a tube. It's as close as we can get to a ventilator without a tube. With BiPAP, you're gonna have a higher pressure when they breathe in, and then a lower pressure when they exhale. When they inhale, it's gonna get their PO2 up. When they exhale, that lower pressure is gonna help to suck some of that CO2 out. So this is the only non-invasive method that we're going to talk about that will actually decrease your CO2. You're going to have to educate your patients on this because they hate these things. They do not like to wear them. So a lot of times your patients will argue with you and tell you that they don't need their BiPAP because, look, my oxygen sat is 99%. You have to explain to them why they need a BiPAP because they also have to get rid of their CO2. And I have this conversation with families all the time because their loved one is just miserable with this mask on. If you tell them why, a lot of times they're more receptive to wearing it. Complications of COPD, secondary pneumothorax, because all of those alveoli are stretched all the time. Sometimes they can pop. And sometimes it can cause a bleb in the lung that's a pneumothorax, which would be treated usually with a chest tube, which we're going to talk some more about next week, I think. And then right-sided heart failure, we won't get too deep into this because you're going to have it again when you get to critical care, but the increased pressure in the lungs causes the right side of the heart to have to work harder to pump the blood. So after years of working harder, it eventually will start to fail. And then you have right-sided heart failure, which is cor pulmonale is what that's called when it's associated with respiratory failure. All right, let's get back to Doris. So what assessment findings might we look for when we're examining her? Somebody tell me.
Her color.
Say again?
Her color.
Her color, yep. What else? What might Doris look like? Barrel chest, there you go. We're gonna assess her chest. What else? Positioning, yep. How's she sitting in the chair when she's talking to us? What questions might we ask her when we're taking her history? How long has she smoked? What else?
Her work history.
There you go. We're gonna ask her what she did for a living before she retired. Anything else? You usually also want to know how much they've smoked a day, because that's going to be relevant. Here are we've got 2 pages of assessment findings that you might look for on Doris. You're going to look at her cough, her sputum production. You want to know what her sputum looks like, changes in skin color, we talked about that. How is she talking? Is she gasping when she's talking? Positioning, tripod positioning. Here are some nursing diagnoses you can look at. They are very much the same as what Dr. Wilhite mentioned earlier. Also anxiety with these patients related to their breathlessness. And activity intolerance is a big deal with these patients. They usually are very frustrated because they can't do what they used to do. So nursing interventions, we're going to administer our bronchodilators. We're going to give them oxygen, but not too much. Assist them with positioning. Sitting up helps these patients a lot, just like any other respiratory distress patient. And then we're going to go back to the small, frequent meals that we talked about earlier. These patients, a lot of times they don't eat a whole lot, one, because they can't breathe. So it's a lot of work to breathe and eat at the same time. The other thing is that when they eat large meals, even just a large meal will put pressure on that diaphragm because they already have lungs that are hyperinflated. So they eat a big meal and then they feel like they can't breathe after. So they end up eating less just naturally. Sometimes these patients, like, maybe just offer them snacks. And a lot of times they need high-calorie snacks, not always, but you're going to talk to your physician and your dietitian about that. Try to encourage them to eat small, generally healthy snacks. And then education points, breathing techniques. We talked about the pursed lip breathing. Pacing their activities is a big one. We don't want to tell people not to exercise, but also we don't want them to get in trouble either. So we're going to tell them that they can still, in a lot of cases, do the things that they want to do, but they need to plan to have a little more time to be able to pace themselves and take breaks. Smoking cessation, if they're still smoking, they really need to stop. That's only making things worse. And then vaccine prophylaxis is one that's a big deal for these patients because a lot of times the exacerbations are caused by some infection that sort of throws off their compensation mechanism. So the flu, these are the patients that the flu really causes problems with. Pneumonia is the same. Your pneumonia vaccines, they need to be up to date on those as well. And coping, again, these patients are a lot of times very frustrated because they want to do things and they can't. So they can get really depressed and frustrated by that. The pursed lip breathing. One thing that I want to talk about is when a patient is in trouble and anxious, how we tell them to pursed lip breathe. So what I tell them is, smell the roses, blow out the candles. And we talked about that's going to help them do what? We asked this earlier? Get rid of their CO2, correct. And this is a way that you can very quickly coach them to do pursed lip breathing. Care outcomes, we want to improve their activity tolerance. We want to decrease their ER visits, and we want to decrease their hospitalizations. Remember, COPD is not curable. So we're just managing their symptoms and improving their quality of life as much as we can. So now we're going to talk back about smoking because we talked about it earlier and how most cases of COPD are caused by smoking. So this is not like a graded question. I just want to talk about it for a second. How do you guys think that attitudes have changed about smoking, or have they changed? What do you guys think? It used to be a cool thing to do. Do you think it still is? Do you think it's not? What do you think? Okay. Yeah, actually you anticipated my next slide. So you think smoking maybe is now less glamorous, right? But there are other forms of tobacco or nicotine that have kind of replaced it. Another thing that we know about smoking is that the people who are still smoking are usually the people who can least afford to do so. It's very highly prevalent in poorer populations, people that work minimum wage jobs. Why do you think that is? Stress, yeah. A lot of these patients, they know smoking's bad. They get it. They've been told that many, many times. They know it. So us as nurses, when we provide education, if we just tell them, hey, you need to quit smoking and here's your paper that I have to give you to check off my charting. Well, you're not going to make a lot of difference to them. They know. So what we have to do as nurses is think about why they're smoking. You know, a lot of them, if they're poor, maybe they have mental health issues and they can't afford to go to the doctor about it, so they're self-medicating. That happens a lot. A lot of times just a little bit of empathy and understanding from us can maybe, you talk to them about it, why they're smoking, what's causing them to make these choices, you're a lot more likely to actually impact them and make them think about it, make them decide to make different choices. And we mentioned vaping. So we don't know with vaping yet. It hasn't been around long enough to know how it's going to affect people's lungs long term. But one thing about it is kids are definitely doing it more, and we do know that vaping actually leads to smoking, because kids in middle school, my stepdaughter, they vape in the locker room before basketball games, you know. Vaping is seen as less dangerous, it smells nice, it's not as bad. But we do know that when kids get addicted to nicotine, later on, when maybe they don't have access to a Juul pod, maybe they buy a pack of cigarettes because that's easier to get, and it definitely leads people to have higher rates of smoking. Smoking was declining for years, now it's ticking back up a little bit. So we do want to address vaping with our patients. So with Doris, she mentioned that she's been losing weight. She says she just can't eat big meals anymore because of her breathing. So what are we going to suggest to her to help improve her nutrition? Smaller meals, snacks. She is discouraged because she says that her breathing is keeping her from doing the things that she enjoys. How are you going to educate her on to being able to continue her hobbies? A little louder. Yeah, give extra time. Pace herself. Don't get discouraged when she can't do things as quickly as she used to be able to. And then finally, she says that her doctor keeps pestering her about the flu and pneumonia vaccines. She said she had the flu last year and she was fine. Why do I need the flu vaccine? What would you tell her? That's right. It can cause an exacerbation. And now that her COPD is getting worse, she is getting higher risk for serious complications. Flu and pneumonia vaccines can keep her out of the hospital. All right, so there's our references. Now, what questions do you guys have? I know you guys have some. Meds, emphysema, differences. What can I clear up for you? Come on. Anybody? Everybody good? Everybody gonna make 100 on the test? Okay. We don't know. Well, maybe.